Well, good to meet you all. My name's Kian. I shared some stories with Uli a while ago, and we met. So thanks for the invite. I was a Kaiser doc for 6 years, and a lot of the Kaiser life I do miss, but it really had a calling for another area. So I left medicine about 3 years ago to really scale SpineZone. I, as a surgeon, really felt firsthand how much we overtreated these patients. We were considered the top of the pecking order, the top of the food chain, but we really had amazing answers to such few questions, and everyone considered us to be experts. And there was so much we did not manage very well. So we knew the overtreatment rate was about 60, 70%. Patients who were on narcotics that didn't need to be on narcotics, had surgeries that were unnecessary imaging. Even at Kaiser, we're not incentivized monetarily to do anything more. But when patients come with a problem and we don't have a great solution, we end up operating. I had a mentor of mine say, once we've reached the end of our thinking as surgeons, we operate. That's the tool we have. So left a while ago because this problem we saw was so massive. Uli presented the numbers a while ago, but it's well known to be about $100 billion in costs, direct costs. If you look at the indirect costs, about another $100 billion on top of that. Missed days of work, lost productivity. Right now, for all major health systems, health plan, it's right up there as one of the major priorities to fix. So what is the problem? The reality is, in the system right now, if you go to any care provider, the next step is going to be very different, whether it's PT, chiropractic. And so you have unpredictable costs, unpredictable outcomes. It's the second most common reason to see the doctor. And basically, you end up in this maze. And if you go to any traditional non-operative pathway right now, whether it's PT, acupuncture, chiropractor, throughout the system, it's about a 6 to 8% rate of surgery. So pretty high. And again, the actual true, if you look at what is truly indicated for surgery, it's a very narrow sliver of patients who actually need surgery. So what have we done? We've taken really all the literature that's out there. We've looked to see what areas people research: strengthening, posture, cognitive behavioral, anxiety, depression, catastrophizing, really unique activities to do per each diagnosis. We've bundled it into one system, and we've created a system that's very predictable, and we've been able to show a 75% reduction in narcotics and medications, and we have a 2% rate of surgery. And so this is really what we've been scaling, where our passion is around, because in the end of the day, it feels like the right thing. I've known it as a surgeon when I've seen patients that have the worst disease and something happens and they try and they don't do the surgery I recommend and they get better. I knew that there was something we didn't understand. So this pathway has been a deep passion of all of ours, and we're really excited about it. So we were fortunate enough back in 2010 to actually study it. We looked at our pathway versus the traditional pathway. So we wanted to look and see what is the true value that these systems get as well as the patients. So we took our pathway, compared it to the traditional physical therapy pathway, already in a system that was highly optimized. So Sharp's system was already leading capitated care, managed care. They were doing a great job. They still realized there was an opportunity to save costs. Once we looked at it across all the different pathways, the professional fees, the imaging fees, ER, hospital fees, DME, medications, across the board, we saw a reduction. And so we really recognized that there was a huge opportunity nationwide to provide this value. And so, again, to reiterate, what is really how we do this is to take a breadth of literature that has really shown very clearly what needs to be done. We bundled it into one software system and program so that we could provide this at scale with these basic tenets that I described. Quantifying every one of these areas. We quantify your strength with commercially available hardware. We quantify your posture, how much your neck is forward, how much your shoulder is off. We quantify and screen for anxiety, depression. And then along the way, we've now had over 100,000 live patient encounters. We can tell if you're a 45-year-old diabetic whose shoulder's a little off, who's not progressing with their pain and range of motion, we can customize that treatment in a very data-driven fashion to then make sure that patient stays on track, doesn't get the MRI, doesn't get prescribed the narcotic. And so really the way we manage the whole market is to do an online assessment. We'll first, with our partners, and I'll talk about who those people are in a sec, we do an online assessment. So you answer 13 questions that tell me, okay, where's your pain? How well are you coping? Are you having anxiety over it? Have you consumed any prior healthcare resources? Have you had an X-ray? Have you had an MRI? Have you had a surgery? We then risk stratify you. Based on that risk stratification, we'll then put you into two categories. Either you're low risk, and you can go into our online program, or you're high risk, in which we know you need further intervention. We need to look at the white of your eyes and help guide you during that system. And so we realize if you do this in a very structured fashion, this is where you can create a highly optimized system. This is really our approach to the market. And at the end of the day, we recommend when you need an X-ray and an MRI. And so that's the key thing. We don't want to provide that care. We want to give that data to the provider to say, you know what, this patient truly has failed non-operative measures. As surgeons, this was a black box we all checked. And let me tell you, all surgeons still do it. You walk into a surgeon's office and you say, you know what, I did PT and I failed it for 6 weeks. Guess what? They're sharpening their knife and I was salivating like every other surgeon. When that black box is checked, you've done your job. Now we can truly say that actually this patient has failed non-operative measure. And now we can truly say you need the next step. So we have a ton of data coming in, and this is really what drives our outcomes. So we have the patient-generated data. This is patients telling us how they're functioning. And we really use this data to, again, customize the treatment. And at the end of the day, have transparency into how these patients do. We get these long-term outcomes 3, 6, 12, 24 months later to make sure these interventions actually don't just avoid surgery for 3 months, but actually long-term can avoid. We have objective data that's coming in when they come into our clinics as well that look at the actual posture, the strength as well. And then at the end of the day, we see how patients behave. How compliant are they with the exercises? How much are they logging in? Are they consuming the content we give them? Education is such a key piece of this. Patients don't know that 60% of disc herniations actually get better. You may have miserable pain and you may be totally debilitated. But if we can bridge you through that period, you're not going to get the gift that keeps on giving, which is back surgery. You get one little discectomy, take out a little bit of your disc. Guess what? The rest is going to herniate. You'll get the next level. You get one level fused. It's the gift that keeps on giving, is back surgery. We can prevent that terrible cycle by getting at it early. So this is just a summary of our patients from 2016. About a quarter of our patients have missed at least 1 day of work. We see patients, we've changed this now. We're coming earlier in the pathway, but a lot of the patients that are coming to us have had pain for over 3 years. And so we realize we have historically as a company dealt with the tough patients, and now we're going earlier in the care pathway and managing these patients as soon as they get back pain in a very preventative way. And so you can see they're utilizing a lot of resources, again, that we want to prevent. And I won't spend a lot of time on these outcomes, but basically we do all statistical analyses on all our outcomes. So we have p-values that are built in. We went through the effort of doing that. You can see pain levels decreased with an N of 706. With an N of 1200, you can see the reduction in narcotics for NSAIDs, bless you, NSAIDs, narcotics, anti-inflammatories. These are functional outcomes that have improved. Again, these are patients that are walking, lifting, traveling, the basic ADLs that you need to function on and have improved. And so, you know, it's been an exciting time. I think Sasha said it totally correctly. These systems have no idea what they're spending. they have no idea. And there's such a buzz around, risk management and having risk contracts and value-based medicine. We're really excited. We just signed a contract with Scripps Clinic last month to manage their 150,000 members. There are 20 clinics that are all referring to our system, and it's a risk arrangement. So in the end of the day, we're saying we want to be responsible for lowering costs and having better outcome. So we've projected the cost out, which was a lot of work. And if patients have too much surgery, we're on the line for it. We know right now what an optimized system should look like. So we understand the data, and so we are comfortable taking this financial risk because in the end of the day, we'll bear the savings as we're reducing that rate of surgery. So it's an exciting time. We've saved over $8 million in the last 8 years. We've had over, now to date, 8,000 patients that we've managed with over 100,000 live patient visits. And we're really excited to be leading this pathway. So thank you. Thanks. Yeah, yeah, double-edged sword. I think you're probably able to look at it objectively, and a lot of patients need that comfort. But the reality is, there's studies that actually show your outcomes are actually worse getting an MRI because the majority of time you'll find something, and 60% of patients older than 60 will have a disc herniation. So if I get it for a patient that's younger, good chance you'll have an abnormality that has nothing to do with your pain. That's the toughest thing as a physician, because patients come in and say, look, I'm in pain. How can you tell me that something's not wrong with me? And the reality is, and that's the tough part, that's why we need to coach these patients and talk to them and listen to them, because the majority of time, if you have a normal physical exam, you could be absolutely in the worst pain ever. You don't need an MRI. And if you get that MRI, your outcomes are going to be worse. So fortunately, you had a good outcome and it helped you. But I, like many physicians in here, we fight very hard to not get that MRI because it's a terrible cascade. You'll find something, you're not sure it's related to your pain, you'll address it, you may or not get better, and then it starts this terrible cycle. Yeah, no doubt. I fully agree with you that that education bit is the key thing. So that's a tough thing to have early on in that pathway. It's a lot of fear that we're addressing. Patients come in with even a neurologic deficit sometimes that you have to educate them what the natural history is. So it's great you got that peace of mind, and that's what we always try to give our patients is that peace of mind that it's not going to progress. It won't. And sometimes the reality is, I, as a physician, still do it all the time because at the end of the day, patients need that comfort. So it's still, again, that's why medicine is an art. It's not, nothing is black and white. So it's great that it worked out for you, and I think for many people it's always customized. But as a population, when you look at overall managing a population, you generally, they're pretty good guidelines on when to get MRIs. Yes. It's about it's about 13 questions, so you can do it online on your phone. It takes about 5 minutes or less. Yeah, the reality is online, the main thing you want to check for is red flags. So you want to make sure the patients, don't have any of the areas that you don't want to miss. So you don't have an infection, you don't have a tumor, don't have a fracture. There's a slew of things you don't want to miss. And as long as you can screen for that adequately, majority of patients need to be educated, they need to be on the right path, and the majority of patients don't need to go to their doctor, don't need to be on an NSAID. And so we're coming in with the perspective that, sure, you don't want to miss that segment of population that truly needs to see the doctor, or they had a trip and fall, and they need to get an X-ray. But you can appropriately screen for that. And the reality is, it takes a lot of, we have trained staff that needs to be aware of these red flags so you don't miss it. So, when we sign this partnership with Scripps, what we're hearing is all the primary care docs telling us that, we have a slew of patients that need better care that we don't have the bandwidth to manage. And so it's such a common complaint, and we need to get these patients down the right pathway to get them better. And so many come in and needing more care, but they don't have the bandwidth to do it. So this is allowing them to get better, get on the right path, and not need a PCP visit. Yes. Yeah, great question. Love that, because it took us nothing short of blood, sweat, and tears to get there. So basically, third-party analysis from an actuary that went back 3 years to calculate PMPMs, and then we projected out, like Medicare, the next 3 years what the PMPM should be, and then we set guidelines if we're above and below. If we're above it, we essentially give a service credit. If we're below it, we would benefit in the savings. Yeah. So, really excited to announce that we just got a partnership with Anthem. So, Anthem, again, most payers recognize us in their top 5. So, payers are now recognizing the partnership we have with Anthem really services their employer groups. Um, Overall, payers traditionally haven't had a care delivery system to do this. Anthem is better. Optum obviously does this with United. So payers recognize it. The lever we have with Anthem in our partnership is that they actually can change care pathways through their employer relationships. So it's right now a hot topic that all employers are talking about. Boeing, all the big employers know that back pain costs are one of their top 1 or 2 spends, especially when you calculate lost days of work. So it's on the priority list. Historically it's been diabetes, heart disease, but as Uli showed, everyone's recognizing that this is a huge area right now. Yeah, I'm sorry. So yeah, we can right now bill telemedicine for the PPO contracts. We're billing telemedicine codes, and as well for the on-site, we bill PT codes for that. So longer discussion regarding specific codes, but I can kind of follow up with you. Yes. Yeah, so we're right now predominantly a B2B play. So we have, a slew of signed contracts with these health systems and medical groups and health plans. But we're transitioning over now that our online program is growing to now do more online marketing to grow that as well. So traditionally, we're getting referrals from the primary care docs. So right now we're mostly in California, and with our relationship with Anthem, we have basically the next 12 months to service their employer groups in California, and then months 12 to 24, we're going to 14 states that Anthem has a license. So that's our expansion strategy. I was at Kaiser for 6 years, so I knew all those orthopods. Highly political system, and yeah, gone down that path, and hope to be there back soon.